Hello, everyone. My name is Dan Stasek with the Craneware Group, and I have the pleasure of introducing our next speaker, Kelly Randza. She has 12 years of experience in the healthcare finance and operations side. She has been at UPMC, University of Pittsburgh Medical Center, for 8 years in managing staffing and productivity, and now she is with the Craneware Group. Kelly focuses on implementing decision support tools. Please give a warm welcome for Kelly.
All right, thank you, Dan. So we are going to be talking even more about data today with my presentation, only this time I'm going to sort of be shifting the focus from payers and billing side and moving it over to the labor productivity and staffing side. Now, in my experience, anytime I speak with the two major stakeholders when it comes to labor productivity and staffing, which is your clinical managers and finance, that discussion is impassioned, and that's probably putting it nicely. Typically, both of these sides, clinical managers and finance, seem to have diametrically opposed outputs, main objectives during that conversation. Finance is trying to reduce staffing, reduce costs as much as possible. Clinical managers are trying to hold on to their staff as much as they can. But there is some common ground during these discussions, and that is general frustration. And I say this from my own experience. When I was 23 years old, I had been working in healthcare finance at a corporate level at UPMC for 2 years. I started a new job at Children's Hospital of Pittsburgh, managing operational finance. My first day, I was handed a list of departments, a mixture of nursing departments and ancillary services, and I was told, help these departments manage their labor. They handed me a tool. It was a homegrown resource management tool. And they said, this is going to have all the information you need in it. Look at their reports. And by the way, we have a nursing unit that has been 2 FTEs overstaffed for months. I need you to go have a discussion with their clinical manager, their nurse manager, and figure out what's going on and find a solution. So me, being a dedicated analyst, I pulled all of their information out of that system. Their current productivity, their overtime hours, their volumes, and I put it all together in a packet and made an appointment with their nurse manager, who had been in nursing for 30 years and managing that department for 10. I was a lamb being led to slaughter in that conversation. Naively, I sit down and I say, hey, here's all of your data. Let's talk about why you think you have been overstaffed by 2 FTEs for so long. And I will always remember her response, which was, I'm not. I'm not overstaffed by 2 FTEs. Your data is wrong. Now, I work for a large hospital system. I'm like, there's no way this homegrown product could give me data that's bad. I said, what do you mean? She says, well, my nursing unit has become overflow for the step-down unit. We need to get patients out of the ICU when possible because our ICU is overrun. The step-down unit is also overpacked with patients, so they're using our nursing unit to house them. Those patients need a much lower nurse-to-staff ratio, and that has never been taken into consideration when building this product and giving these results. And I know I have 80 hours of overtime for the last pay period. It's because you guys, finance, have not approved my 2 vacant positions. So of course, I have to use that overtime to help staff my unit. And I'm looking through all of my data, and I have no answer. I had to say, let me take this feedback and let me see what I can do. So I go back, and I have always been and still am a data nerd. So I go, okay, I need to either prove or disprove these anecdotes that I'm hearing from this nurse manager. I want to help her. I want to make sure she gets those positions approved. I want to make she is not truly overstaffed. So I start looking at all the data systems. I look in our resource management application. Nothing in there helps me answer that question. I go, okay, she's saying that she has patients that are technically step-down unit, but are sitting on the nursing unit. She had also mentioned she had a few patients that deteriorated, needed to be put on vents, but there was no space for them to go back to the ICU. How do I prove this? Like, okay, I have to go to the electronic health medical record. At that time, it was Epic. Like, all right, let me get access to Epic. Only people who have been approved and trained with a license in Crystal can get Epic information. I was not one of them. So I had to find somebody that had access and ask them to pull data for me. I also needed to get more detail into what types of nurses and what types of employees were working on what shifts. That information is not available in payroll. I had to look to Kronos, to the time and attendance system, which very few people knew how to pull data from. So suddenly I have all of this data, more than Excel can handle. At that time, Power BI was just being tested. It was just released. I was one of the first people there that started using Power BI. Maybe this will help me manage this data. I spent hours trying to, all I needed to do was prove or disprove what this nurse manager was saying, this is what I see every day. And this is not incorporated into your model. And I couldn't. She was frustrated, I was frustrated, and there was nothing that could answer any of my questions. So I went to my director and I said, this is what I have. If you squint and you turn your head to the side, you can kind of see what she's saying, but I don't have any empirical proof that this is what's happening and that we should be changing their standard or that we should be changing our model. And he said, well, their 2 FTEs overstaffed based on this model, which they agreed to. They won't be getting those positions approved. So when I moved on from working in healthcare finance to working on the software development side, I wanted to fix this problem. And this was not a problem of nurse managers not understanding finance or finance not understanding nurse managers. Of course they didn't understand each other. They couldn't agree upon the reality of what was happening in the hospitals. So that was the problem when I had the opportunity and the resources to solve, and I found the solution in operational intelligence and incorporating it into how we look at labor productivity. Let me make sure I'm able to use this. Yeah, I'm having the same technical difficulty.
I think it was the mouse first and then.
Okay, all right. There we go. Let's see if this, there we go, thank you. All right, so before I actually start talking about operational intelligence, labor productivity, everything that goes into it, I want to actually talk about why this matters, especially in the current climate of healthcare. So I think everything on this screen, for everybody in this room, none of this comes as a surprise to you. These are all of the challenges that you are facing. Increase in unpaid care costs, increasing costs generally, especially with supplies, reduction of margins, an aging population that's requiring higher levels of care, inflation. You know what you don't see on here is increasing labor costs, because that is a symptom of the larger problem, which is a workforce shortage. If you do not understand the problem, you will never find the solution. So, workforce shortage. How does that line up with what we're seeing from a cost perspective? We all know that labor cost is the largest expense and the fastest increasing expense on everybody's bottom line. In fact, in the last 3 to 5 years, most hospitals have seen an increase in this expense of 258%. And when healthcare leaders in 2023 were asked, give me your top 5 concerns and roadblocks in running your business, 69% didn't say labor costs, they said retaining employees. This increase in cost is actually due to that labor shortage, which was very much and very obviously impacted by COVID-19. increase in staff burnout, increased usage, very sick population. They started seeing burnout, and they started seeing turnover. And unfortunately, this is a cycle. You end up having turnover. You need to use overtime to fill in that turnover. Your staff gets burned out, you get more turnover. Maybe you fill in those empty positions short term with agency staff, which costs you 2 to 3 times more than your standard staff RNs. And then those temporary agency staff somehow are still there 2 years later. Because now agency staff is muddled in with your over or under staffing outputs, and no one can prove that you actually need that permanent position. There's also an inherent cost of turnover that isn't just related to replacing with agency staff. Training and that time of onboarding does cost you money. There's also an efficiency component. A lot of these units, these people have worked together for years. They work incredibly well together. It's like a well-oiled machine. You remove 3 of them and replace them with newbies, people that don't maybe know the procedures or protocols of your particular hospital or that particular unit, you're going to see inefficiencies in care for a period of time. And if you're constantly dealing with that, that has an inherent cost all on its own. So, with all of these problems in a nuanced industry, with nuanced issues and many variables impacting the overall outcome, what do we do? In my opinion, in all the research and experience that I have, it is incorporating operational intelligence. Before I talk about how to incorporate it, I want to talk about what it is. The purpose of operational intelligence on a highest level is being able to monitor business activities, identify inefficiencies or opportunities, and here's the really important part, provide operational solutions. Every hospital's labor productivity system they have now identifies inefficiencies. Very rarely does it give enough information to provide you with a solution. So what does operational intelligence actually do in this scenario? What it does and what it enables us to do is to connect all of these disparate data systems into one, you could consider it a data lake. It can take your electronic health record, all the information in it, which that is, if you've never been able to actually dig deep into all the data that's available, the world is basically your oyster once you are able to connect all these sources. So you can connect your electronic health record with your patient billing system, with your general ledger, with your time and attendance system, with your payroll system. I've seen hospitals that all 5 of those are completely different systems from completely different companies, with no way of tying it except for maybe one identifier hidden in a table that's 3 layers deep in the data model. What operational intelligence allows you to do is to connect all of these, and that is where you gain the insights. And then I just have an example here of what the difference between identifying a problem and offering information that can lead to a solution. So this is just an example of a hospital-acquired infection rate. 2022, this example, 4%. That is great information to have. What does it mean? What can you do? What impact has that had? When you are able to connect all these systems in a singular place, you're able to identify our hospital-acquired infection rate was 4%. On average, these patients cost us $20,000 more than compared to the same patient group. And those units where those hospital-acquired infections were occurring on, during that period of time of that patient's stay, they were 15% understaffed, but their labor costs were 10% higher than budget due to overtime and agency. Now, you know where to start. You know where to start looking when looking for a solution. And this is just an example that isn't even related to labor productivity, but that is the power of utilizing operational intelligence. Now moving on to the actual topic at hand, which is labor productivity. I believe that historic systems and legacy systems and the way that many areas still look at labor productivity look at it from that simple definition. The labor output per healthcare worker. When your labor output is saving lives, that is an inadequate definition. The more complex definition would be to measure how efficiently either a hospital, a service group, a department, or even a job category such as an RN groupings, LPN groupings, how efficiently you have utilized your labor resources to treat not just your patient activity or volumes, but the patients themselves and the services they needed. Simply put, you have the right people in the right place at the right time performing the right service. Whoop. There we go. That is an incredibly complex question to answer, and that is the definition we need to be utilizing when looking at labor productivity. Now, to do that, to understand, did we do all those things, and if we didn't, how do we fix it? You need to be able to do a deep dive into the two variables that impact your labor productivity, either your patient activity, your patient population, and the labor resources. You put those together, that is what impacts your actual productivity of your labor force. So the purpose of this is not just to find costs and reduce them. A good system is going to allow you to balance the efficiency of your staff with the effectiveness. You can have a department that statistically is incredibly efficient. If they are too efficient, it means they are very understaffed, and you're going to end up affecting the effectiveness that that team is able to provide services, whether that's with quality of care. You can no longer provide specific services because you don't have the people to do them. Or even a nuanced example. You have a department that looks incredibly efficient, and they're meeting all of their staffing budget needs. But they are primarily staffed with LPNs when the services required needs a certification of an RN. So they're having to outsource some of the services and some of the work to other areas. That is affecting effectiveness, even though you're efficient. So you want to find that balance, and any good system should allow you to do so. So what is the actual key, and what is the difference between legacy systems and those that are used in operational intelligence? And it is entirely the data, specifically the data sources. Legacy systems, standard protocol, and it's been like this for years. I was actually shocked when I left hospital operations, started working in software. 10 years later, you're telling me they're using the same stuff as 10 years ago? How has this not evolved? So the two data sources they are using, patient billing, AKA charges. This is what they're using to determine patient activity. Unfortunately, that data source, charges, was never intended to be used to actually identify what is happening to a patient and what their care needs and resource consumption was. It is a function of billing. There's also payroll is the other piece. Patient piece is patient billing, employee piece is payroll. Now inherently the limitations of payroll is it's every 2 weeks. You will only know how over or understaffed you were every 2 weeks. For some hospitals, it's every month. Because sometimes it's such a lift to run these systems, these productivity systems, they'll only do it monthly. At that point, if you did have an inefficiency, you've let that go for 2 weeks or a month, and that does have significant costs associated with it. It doesn't take long for a team to get burned out and someone to decide to leave. If you're incredibly understaffed, by the time you realize it or you're able to see it as a finance person in the data, it might be too late. Now, let's look at the other side of the coin, operational intelligence. You're using everything in the electronic health record. What does that mean specifically for this? We are no longer determining patient activity by charges. You are now looking at how much time a patient actually spent in a unit. You're not extrapolating that from charges of saying, well, here's a bed census charge. We're going to assume that's 24 hours. With the admission, discharge, transfer feeds that are available and required in every electronic health record, you can see exactly when a patient entered a unit and when they left. When they entered the OR, when they left. When they left to go get physical therapy, to get radiology. You now know exactly where your patients are at any moment of any day. You also have the other side of the coin, which is your employee clock in and clock out information, or time and attendance, a system such as Kronos. This allows you to get the same information for the patients but for your employees. You're able to see every day how many nurses did I have staffed between 2 o'clock and 4 o'clock. Did I flex staff appropriately? You're now able to answer that. This gives you the ability to actually understand where your patients are, who is caring for them at any moment of the day. Plus, with the electronic health record, you can look at things like patient acuity. Were they on a vent? Did they have a diagnosis with complications? All of those things can impact how an area would staff. They are, at the end of the day, staffing to the needs of the patient. They have to. And then we are able to use patient billing and payroll as just supplemental information, supporting evidence. But your real evidence is coming from those other two data sources. That is where you actually unlock all of the potential. And this is the outcomes. The assets, reporting assets. What are you actually receiving from this system? Current standard, biweekly or monthly reporting. We've already discussed why that is not an ideal situation. Static dashboards. What do I mean by that? Many systems, you get a PDF. Here's your patient volume. Here's your standard. Here's how many FTEs you're overstaffed. Here's how much overtime you had. For the last pay period, maybe we'll compare it year to date. Maybe we'll compare it to the prior pay period. Rarely are you actually able to say, let me see this trended instead of by day, by week, by month. Let me add regression lines, see where I'm going statistically based on the last 2 years of operation. You're not able to do that because the data just doesn't support it. You're also dealing with charge-based models. The limitations of that are you're losing all of the nuance. A bed charge only happens at midnight. You could have a patient that spent 10 hours on a unit, for whatever reason was moved off, into a different unit at 11 o'clock at night. That new unit is going to get credit for that patient being there all day in the previous system. And the unit that had to have a nurse caring for that patient, it's like they were never there. Which once I started realizing this, I understood why that nurse manager was so combative. I understand it. She's saying, you are living in a different reality than I am, and if we can't agree on what's actually happening in my unit, then we're never going to have a constructive conversation. Also, high-level statistics. You're looking at your productivity by department, high level. You're actually going to get insight if you're able to see how well did you staff your RNs in that department. You may say, hey, you're 2 FTEs overstaffed. Great. Where do I pull them from? Is the inefficiency actually happening in your RNs? Or is it in your clerical and LPNs? Is it in your other clinical support staff? Is it in management? Knowing where to actually enact change is going to make that change more effective. You can't go into surgery with a sledgehammer. You have to use a scalpel. And this data supports that. And then finally, average patient activity indicators. When I'm talking about patient volume that is being reported, typically when they're actually calculating your productivity, we're talking about here is your average patient day per day of the week. So let's say you have a really bad snowstorm. Typically, there are more car accidents. People get frostbite. You're going to see an increase in volume at your hospitals. Say that lasts 4 days. All of that increased activity and the resources that were required to care for those patients is now spread like peanut butter over the entire pay period. With the current reporting, you will never be able to say, how did we manage staffing during this crisis? Now, let's compare it to the operational intelligence side. You're getting real-time daily reporting because you're actually getting the timestamps from Epic. There is no need for a person to go in and change those timestamps. They're fairly reliable. You also have the employee clock-in and clock-outs. Now, you may change day to day. Maybe someone forgot to clock out. It wasn't correctly categorized, but generally, you're going to get an understanding of who worked there day to day. This way, I'm able to see, hey, we had really high volume. We had a really bad snowstorm yesterday. How did we handle that? Is there something we can learn from how we staffed? You're using an ADT feed model, admission, discharge, transfer. Your patient activity is based on real timestamps. As a finance person, the only insight we ever get into what's happening on the floor outside of us standing in the middle of a nursing unit is through our data. That is our view of what's happening in our hospitals. So imagine if that view is at that level of detail. You're getting a really accurate understanding of what's happening on those nursing units. You're getting detailed statistics that are tailored to the services. You should never just say, oh, this nursing unit is 2 FTEs overstaffed. What's the biggest variable that impacts how they staffed? It's going to be their occupancy rate. This allows us to say, all right, for all the nursing units, we're not just going to give you your productivity outcomes. We're going to give you by hour what your occupancy rate was throughout the day for the last week. We're going to be able to tell you statistically when you typically start seeing discharges, how well you're flexing your staff when you begin to see discharges, when are your admissions typically appearing. For an ER, that occupancy rate is not going to be a major variable in how they staff or their OR. Instead, they're going to look at how many scheduled surgeries do we have? On average, how many emergency surgeries are we having? In what service lines? Is it neurology? Is it cardiology? Is it general surgery? Who are the physicians that were working during that time in the OR? When you have statistics tailored to how you are actually staffing, again, you're able to answer the why. You're able to understand why you're getting that output. You're also getting all the employee utilization detail. Who was staffed in the morning shift versus the evening shift? Do we change staffing morning versus evening? Do we change staffing in an ER based on the day of the week? Are we staffing more on Thursday, Friday, Saturday, because historically we know we're going to have more volume? Or are we waiting and bringing people in on call or utilizing overtime? You can get that detail. Finally, the piece that everyone in this room in finance is going to love, you can understand the cost impact of those decisions. Currently, very few systems actually assign a cost. But because we are bringing in and combining these data systems, we're able to see your employee roster, the standard rate, what is the overtime rate, what is the holiday rate. And through that, being able to say, based on who you staffed and what type of time they were working, overtime, regular, holiday, we can tell you exactly what you paid. And then we can say, in this ideal situation, you should have paid this, and tell you the actual to-the-dollar impact of those staffing decisions. So now I want to go through just a quick exercise in how this allows you to understand the why. So this is an actual example from someone I have worked with. They had a nursing unit. They caught this on day 2, but it took them a while to actually figure out what was going on. But they had a unit that was on average overstaffed by about 35% on average for 2 weeks. And we could not figure out why. Well, this gave us a really good indication. I know it's kind of small, so I'm going to explain what this is. The bars are your occupancy rate by hour for just one example of those days. So with this, you can actually see where the discharges began around 2 p.m. The line is the nurse staffing rate. That performance indicator is based on if we have 100% occupancy and we are working to our standard, what is the total number of nurses we would need on that unit? And then compare it to what we actually staff. So in theory, these two numbers should be together, or at least very, very close. So off the bat, we know you're starting the day off overstaffed. And then the biggest piece is once you start to see those discharges, they had a flex policy in place. They believed they were following the flex policy. When they saw this, they went, oh, I guess we are not. It was very eye-opening to them because they anecdotally thought they were following it, and they weren't. And we were able to agree on this being the reality. Not to mention, in this model, the rates, the standards, the ratios, nurse-to-patient ratio, they incorporated acuity. So we said, if you have a patient we're able to identify an incident of them receiving event, your ratio goes from 5-to-1 to 1-to-1. If a patient is moved into your med-surg unit but is actually from a step-down unit and requires a 3-to-1 patient ratio or patient-to-nurse ratio, that's what we're going to use to determine how much you should have staffed, incorporating the needs of the patient into the model. If you notice those big spikes, that's when there were shift changes. You have two nurses clocked in at the same time. That's acceptable, that's understandable, but it does give you a visual of, all right, from a finance perspective, when are there shift changes? And in some cases, we saw that spike for up to 3 hours, which those nursing units went, ooh, we gotta work on the efficiency of our handovers. So this is the type of information that it may not immediately give you, this is the exact solution you should put in place, but at least levels the playing field and you can find common ground with your clinicians on, this is the reality. I now see you as a finance person of what you are dealing with day to day. Let's find a solution together. Now, on my point about needing this information to be timely, not every pay period, not every month. A big piece of that is the cost associated. So for this particular nursing unit, they spent about $7,744 on staffing per day. This was only one nursing unit, a smaller one of a very large hospital that had 25 nursing units. $7,744 per day just for that group. When they are 35% overstaffed, they are overstaffed by 87 hours, and that equates to $2,342 per day that you are overspending, per day. So imagine that goes on for 2 weeks. That is $32,788. That is half of a nurse, maybe a little less than half of a nurse, in 2 weeks. If that goes on for a year, that's almost $1 million for one department, one nursing unit, 35% overstaffed. That is the financial impact of using retrospective looks at all of this information. So, overall, what is the impact of incorporating this operational intelligence into labor productivity? You're going to get a much better understanding of what's happening on your units, of the productivity and utilization of your labor resources. You're going to be able to much more quickly identify opportunities, inefficiencies, risks, and do something about them. It's going to make you more agile as an organization. You're going to have access to data models that actually represent real life in your hospital. With operational intelligence, you have basically unlimited variables you can put business rules around, healthcare rules around. When this happens, we're going to change the staffing like this. When this happens, we're going to do this. We're going to take into account acuity. We're going to take into account the type of surgery that's being performed in the OR. That's going to change how we staff for it. And now these models represent real life. You're also going to now understand the financial impact of these choices, not by looking at generally what your overall FTEs looked like and comparing it to your salaries on the general ledger. You're going to be able to go down to your RNs. I overspent on RNs by this much during this time period. Much more detailed. And all of that is going to allow you to make real-life, data-driven decisions about how you staff, where you staff, what you're able to do. So data is truly the answer to at least starting to unpack how we're going to address labor and staffing within our hospitals. All right. I am now done with my spiel. Does anyone have any questions? All right. Yeah, you're welcome.